Hey, good afternoon, everybody. Thanks for joining me today for another talk from the Trauma Geek. Today, I'm going to be talking about trauma triage, particularly going to be doing a talk that I've given a number of times to pre-hospital providers called Interactive Trauma Triage, a review of the trauma triage guidelines. And the purpose behind this talk today is to go over and put in more of a case study format the 2022 pre-hospital trauma triage field guidelines as produced in 2022 by the American College of Surgeons Committee on Trauma. And even though this is a pre-hospital centric talk today, any of you that are watching that are hospital-based providers, I think you'll find this very interesting, particularly if you don't have a lot of experience or any experience working in the pre-hospital setting. To get a little bit more of a in-depth look, um, let's go back one. To get a little bit more of an in-depth look at these trauma triage guidelines, because I'm not going to go over them in any detail today. I've got two other videos that are posted on my YouTube channel. One is a review of the national guidelines for the field triage of injured patients with a little bit of a New Jersey focus. So that video is available on the YouTube page. And then for those of you that are hospital based, I've got a companion video on the integration of the revised trauma triage criteria. They were revised again 2 years ago, almost 3 years ago now. And I did this video about 2 years ago. And this second video is a little bit more hospital provider focused. So the other one is the first one, the national guideline video goes over these what were at the time I recorded the video, the revised trauma triage guidelines, an update from the 2011 CDC trauma triage guidelines, which God knows needed a change. And then for you hospital-based providers, there's a video up there that shows how they reintegrated these revised field triage guidelines into our trauma team activation criteria at my shop, which is St. Joseph's University Medical Center in Paterson, New Jersey. We are a level 2 regional trauma center up there, and a busy level 2 trauma center. And we integrated those field triage guidelines into our trauma team activation criteria, and keeping synonymous with our pre-hospital colleagues. So for those of you who don't know me, my name is Steve Wyman. I am the Trauma Geek. Trauma Geek. On my full-time avocation, I am the uh, trauma program coordinator for research and professional development, again at St. Joseph's University Medical Center in Paterson, New Jersey. Wear a couple of other hats as well as a pre-hospital provider. I am president and an EMT with the Somerville Rescue Squad in Somerville, New Jersey. I've been a member of this organization for about 25 years. And then I also serve as the tactical program coordinator for Somerset County Office of Emergency Management here in central New Jersey, where I run the tactical EMS program. So again, thank you for being here today, and I hope you get something out of today's talk. So I'm going to do a very quick review of these trauma triage guidelines. Again, I'm not going to go into any real depth into them, just a cursory review. For those of you that are familiar with them, you'll see them right away and you know them. For those of you that don't, then I wholeheartedly recommend you go back to those companion videos I showed you just a few minutes ago and look at those to get about 45 minutes to an hour of in-depth information on these trauma triage guidelines that we should be universally using now throughout the country. Hopefully we are. And what we're slow in adapting here in New Jersey is what we do is what we have called the red, yellow trauma triage notification guidelines. There are parts of the state like where I am up in northern New Jersey, where we have wholeheartedly integrated these trauma triage criteria, and our pre-hospital providers know just to call into trauma centers and say, we're bringing a red trauma or we're bringing a yellow trauma. You don't have to worry about what level of trauma team activation it is. Just let us know that it absolutely is a trauma team activation, and whether or not it meets pre-hospital red or pre-hospital yellow criteria, we take care of the rest in the trauma bay. There are some hospitals, unfortunately, within New Jersey, particularly even in the north section, the central, and even the south, that haven't quite gotten there yet. So they're still doing whatever they do to announce traumas that are coming in. But we've tried to make it simple for everybody involved. When we look at these trauma triage guidelines, We start off by always wanting our pre-hospital providers to call ahead. Please, 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 even if it's just 30 seconds before you get there. And it doesn't have to be you. You can reach out to your dispatcher. You can have whoever's driving the ambulance call. But the more advanced notice we have as providers in the trauma center that you're bringing us in a trauma patient, the more time we have to set up, debrief, and be ready to accommodate you when you arrive. So, just like we want to give you the professional courtesy of hearing you out when you come into our trauma bay, we'd like the professional courtesy of having as much notification as possible. Preferentially, as you're leaving the scene, letting us know, or as soon as you've made a determination, if you can hop on the radio and even have your dispatch center call ahead to that trauma center and let them know you're coming. It's greatly, greatly appreciated. Now, when we look at these trauma triage guidelines, you'll see they're set up to be just as I described, red trauma criteria and yellow trauma criteria. I'm not going to go over them today with any degree of detail, because again, you can look these up, you can read them on your own. If you Google field field guidelines for trauma triage. It'll take you to the American College of Surgeons page where you'll have more than enough resources to take a look at these, as well as some additional educational fodder that is there to go over these red and yellow criteria in detail. There's also a canned slideshow that is very similar to the slides that I use in my talks that I showed you a few minutes ago as well that you can go over. Suffice it to say, if patients meet the red criteria, they are sicker. If they meet the yellow criteria, it doesn't mean that they don't need a trauma center. It's just they probably aren't as sick, at least on initial intervention and initial assessment, possibly as a patient who meets red box criteria. Red box criteria are more for injury patterns and physiologic abnormalities, whereas the yellow criteria are more mechanism of injury and then a lot on EMS judgment. One of the great things about these revised guidelines is it gives a lot of leeway to EMS judgment and deciding whether to come to a trauma center or not. And look, at the end of the day, and this is not a grab to get more patients, because believe me, trauma centers already have plenty of patients. But if in doubt, take to a trauma center. An injured patient does better at a trauma center statistically than an injured patient that is taken to a community hospital. And that's just the facts, Jack. So again, I wholeheartedly urge you, if you're not already familiar with that, these guidelines to be familiar with them. And again, call ahead. Very, very important that you do so. All right, so let's go forth. These are cases in review. These were ripped from the Somerville EMS archives. I mentioned before that I'm a 25-year member of Somerville EMS here in Central New Jersey. So these are just a few cross-section of some trauma calls that we've had over the years that I've been involved with, and we're going to let you make the life-saving decision. All right. So case number one is elderly hits head. That never happens, does it, right? So we are dispatched to One Mountain Avenue, apartment 911. We are told we have a 79-year-old female fall with a head laceration. All right. So we arrive on scene. We go into the apartment. It's a very small studio apartment. Patient is sitting in what would be kind of segmented off as a living room, holding a bloody cloth over the back of her head. There's a lot of blood observed on the floor leading out of the bathroom when we arrive. Just a startling amount of blood, actually, to be honest with you. As we start talking with the patient, she's awake and alert. She's able to tell us that she was in the bathroom on one of those little two-step step stools. Was installing a new shower curtain when the step stool collapsed. She then fell backwards and she struck her head on the little sink vanity that was behind her, and immediately started bleeding. She grabbed a washcloth and tried to stop the bleeding with the washcloth, and eventually ended up kind of moving slowly out to the living room area where she's now sitting on the chair and you find her. So knowing that as part of your mechanism of injury and knowing that the patient was able to tell you that very cogently, what are some pertinent questions you might want to ask at this point in time? What do you think? Well, If you ask things like you wanted to assess the overall patient's mental status, you are 100% on board. All right. If you said that you were going to assess a Glasgow coma scale on her at this point in time, you're 100% correct. Obviously, if we're going to do a primary and secondary survey on here, we're going to be thinking about her airway. She's obviously talking with us. She's obviously got a very patent airway. If she's sitting there, sitting upright, is alert and chatting with us. She's obviously breathing well, so we're going to be taking a look to make sure that she doesn't have any laborment of breathing. We'll look at her chest rise and fall. We'll look at her, whether or not she's breathing without being labored. From a circulatory standpoint, we're going to take a look at her skin, her color, her temperature of her skin. We'll take a quick feel for a pulse if we can. Ideally, central pulse is what we want to go for, but if she's fully clothed and sitting in a chair, then just grabbing a quick radial pulse and making sure we can palpate that is good, right? Um, we're going to want to get a set of vital signs on her. And in her particular case, she has a heart rate of 76. She's got a respiratory rate of 12 and unlabored. Her blood pressure is 112/66. Seems not too terribly bad. When we get into a little bit about her past medical history, she tells us she's got a history of hypertension. She's had a heart attack. She's got heart failure. She's had blood clots, and she has herpes zoster. Oh, by the way, she has an active case of herpes zoster right now. So be thinking about that as you're moving forward and handling her and moving her, that she has got on her trunk probably about 2 hands in width, active zouster infestation. She's on a lot of medications, right? A lot of medications. You look at the little pill, I call it the pill bottle table sitting next to her lazy boy, and it's just nothing but white top bottles. So what are meds that we're going to be thinking about? We are particularly interested in knowing from her, right? Falls, hits head, right? First thing that pops in our mind is absolutely any blood thinner she may be on. So is she on any of those blood thinners that, what, we should be aware of out there? Is she taking an aspirin once a day? She's not on a more traditional blood thinner. She's taking an aspirin, which is an antiplatelet. It does thin the blood, so to speak, and it can result in some adverse effects if in someone who hits their head. What other medications might we want to know about with her? If you said something about anything for her blood pressure, particularly, is she on a beta blocker or a calcium channel blocker? Absolutely. We definitely want to know about that as well. We might want to know if she's a diabetic. She didn't mention it in her history, but sometimes people who aren't taking insulin, who have diabetes and are just taking the pills, sometimes don't think that they have diabetes. So you might want to double check with that, again, just to make sure that, maybe this fall off the stool wasn't precipitated by a drop in her blood sugar. But yeah, those are the big ones you're going to be thinking about at this point in time, right? You're going to then get into a focused assessment on her. And when we took a look at her, we found about a inch and a half linear laceration to the occipital area of her head. When we pulled the towel away, we noticed there was a very small arteriolar bleed. So arteries feed into capillaries, but before they feed into capillaries, they go from arteries to arterioles, which are smaller arteries. So we noticed one of these very small arteries was just pumping a little bit of blood, when we pulled the towel away. Towel was pretty saturated with blood, so we decided at this point in time to move away. We got a couple of 5x9s, put 5x9 on her, and then took it this time. This is before Israeli dressings were available out there, because I would have used one of these on her now, and before quick clot too, by the way, but it's an arterial bleed, so quick clot may not have helped. So in this particular case, we did pressure dressing it. We did put direct pressure and hold it, and then we took an ACE wrap and wrapped it around her head pretty tightly. When we palpated around the head lightly, there was no pain with palpation to the posterior skull. She denied any headache. She denied any neck or back pain, and she remained awake and alert throughout our assessment. And I mentioned interventions where direct pressure was applied. All right. Question was, do we want to put a C-collar on her? She was ANO times 3. She did not have any drugs. She didn't have any alcohol on board. She was absolutely, obviously, mentally pristine. And she didn't have any other what we would consider to be distracting injuries. So we elected not to put a C-collar on her at this point in time. So we're going ahead, we're getting our interventions done, and then we got to decide how we're going to transport her, right? And where we're going to transport her to. So again, this is a lady in her 80s. She's fallen, she's hit her head. She didn't have a loss of consciousness. She is on a blood thinner, we found out, but she's not on a beta blocker or calcium channel blocker. But she's ANO times three, never had a loss of consciousness, has been perfectly fine while we've had her. So where would you take her? By ground to patient's hospital of choice, which in this case was a local hospital that was within our town, about 2.5 minutes from where we were assessing her. Will we take her by ground to a trauma center, or do we want to get a helicopter, or do we want to fly her? Right? Three cogent choices. What do you think? Well, we're obviously doing a trauma triage talk, so not naturally you would say let's go to the trauma center. Now, this happened probably about I'm going to say this happened probably close to about 13, 14 years ago. So what we didn't do at that point in time is we really didn't think trauma center was going to be necessary. So we decided we would just head across town and take her to a local community hospital. She's ANO times three, didn't have any other complaints. Bleeding at this point in time was controlled. She was on Coumadin was her anticoagulant of choice at that time. And again, her vital signs were pretty good. So we went ahead and we loaded her up. We double checked the bleeding. There was no bleeding coming through the bandage, so we felt pretty good that we had enough compression on the arteriolar bleed that wasn't a problem anymore. And we started to head out to the hospital, which is, again was about 2.5, 3 minutes away from where her apartment was. Another question came up, do we need ALS? Do we need the paragods? Again, taking a look at what's going on, she wasn't tachycardic. She didn't have enough blood loss that we felt that she was hypovolemic. She wasn't hypotensive. And she wasn't tachycardic. She wasn't on a beta blocker, so we felt pretty comfortable that her heart rate was pretty much her heart rate. She was on a blood thinner, but she was ANO times three, never had a loss of consciousness, didn't have a headache. So nope, don't need them. We actually just suggested we would cancel them if they were dispatched. It turns out they were not dispatched. All right, so we get her loaded up. We're en route to the hospital. We're literally probably about 3 blocks from her house, and she starts to complain of a headache. Within about 30 seconds of complaining of a headache, she has one episode of vomiting. Okay. At this point in time, when this happened and her retro vomiting, she loosened up the pressure dressing and it started to bleed again. So now we've got to contend with the pressure dressing. Within about another 15, 20 seconds, her Glasgow coma score is now dropped to a 13. What do we want to do now? What do you think? So a lot of you are out there saying, well, dummy, you probably should have taken her to the trauma center to begin with. So why don't you start heading that way now? And that's exactly what ran through our minds. Is, okay, this is a little bit different than what we were experiencing with her just 10 minutes before. Let's go ahead and out of an abundance of precaution, let's go ahead and divert and go to the trauma center. Now, the diversion wasn't really much of a divert because to get to the trauma center was the same path we were taking to the community hospital. It's just instead of going straight at one intersection, we took a left, hopped on the highway, and we had about a 12-minute ETA to the trauma center, which is what we wanted to do. So that's what we decided to do. We're going to upgrade her to a trauma, but we're going to also call ahead, right? Call ahead and let them know that we are bringing her a trauma alert. At this point in time, based on the field trauma triage guidelines, you saw me kind of give it away as a little bit of a deal breaker a few minutes ago. She would have met red trauma criteria. She would have met trauma criteria for alteration in her mental status. Her motor score, her Glasgow coma scare motor score actually went from 6 to 5 during this probably first 10 or 15 minutes after we got her out of her apartment, loaded her in the ambulance, and then the couple of minutes we were on the road. So she was a red criteria, which should have meant she would have been activated at that trauma center's highest level of trauma team activation. And that's exactly what we did. We were able to control her bleeding en route for about the 12 minutes that it was taking us to get to the trauma center. In addition to that, she had no more episodes of vomiting. Her Glasgow coma score kind of, caped out at a 13 on arrival. And she ended up having a subdural hematoma. She ended up having a little bit of what we'll call shift on the CAT scan. It was a pretty good sized subdural bleed. They went ahead and they reversed her from her anticoagulants. They monitored her for a few days, and the hematoma did not grow any worse. She did not have any complications needing any kind of surgical intervention. And then she was actually eventually discharged back and made a full recovery. So that was elderly hits head. Okay. Again, Your judgment is your judgment. And our judgment initially was she probably didn't need to go to a trauma center. In retrospect, today, the same person on an anticoagulant who falls back and hits her head in her 80s absolutely is going to a trauma center. No doubt about it in my mind. With the elderly, there are so many occult issues that can go on that we don't see when we initially assess them that I've almost gotten to the point to where every person over 70 or 75 who has any kind of a mechanism of injury that's not simply like, a scrape is I take to a trauma center. Just I see it a lot in my shop, and I see it a lot in talking with pre-hospital providers who are caring for the elderly. All right, let's go to the next one. Gunshot wound at McDonald's. We're dispatched to 356 Route 22 East. It's the McDonald's in town. Gunshot wound victim in the parking lot. Mm-mm. All right, the duty crew is at the building. They immediately call in service. Is there a problem there? Yeah, if you're saying scene safety, you're 100% right. The scene has not been cleared yet. Dispatch just came in. Police are not on scene. They can certainly go in service, but guess what? Don't go anywhere near the scene. So they did call in service, but they called in service letting dispatch know they would be staging probably about a good 8 or 9 blocks from the scene. Okay. So obviously, we're still of this mindset. When you've got domestic violence, acts of violence, don't go balls to the wall, don't diesel bolus it and get there quickly. We need to make sure that our safety is being in check and balance, and that's always going to make sure that scene is secure. All right, so our local police department gets on scene very, very quickly. They do declare the scene safe. While we are en route, our communications center provides an update and reports there are 3 victims on scene. They tell us patient number 1 is a gunshot wound to the head with no vital signs. They tell us patient number 2 is a gunshot wound to the abdomen and is awake and alert. And patient number 3 has a through and through gunshot wound to the hand and is hyperventilating. So you're in the rig, you're the senior EMT. What is your next move? If you say call for additional resources, you're 100% correct. Okay. So you put in the call, you're going to put in a call for either if you have the capacity within your own agency to get an additional 2 ambulances en route, you'll do so. If not, go the mutual aid route and follow whatever protocols you have. All right. You arrive on scene because, again, we're in Somerville. It's a very small town, so we're usually on scene within a couple of minutes of leaving our building. In our rig, we have a crew assistant and 1 EMT. So we have 2 medical providers and then a person who can help us as a gopher. What's our next move at this point in time? Yep, if you said triage, you're 100% right on. So our scene size up. And our initial triage is PD is doing CPR on patient 1 near the drive-through pickup window. Patient number 2 is lying near the front door. Patient number 3 is sitting on the curb in the parking lot. All right. The chief is calling you on the radio. Okay. We do have ALS providers. That's 8 Alpha 2 is en route from Hillsboro. Boy, it was spelled Hillsboro, which is probably about 10 to 15 minutes away. And then we then hear a secondary ambulance from our agency go in service, and then a third ambulance from a mutual aid company go into service. So we know the cavalry is coming. All right. So what's the next move, right? We've got a scene size up. We know some resources are coming. Hey, let's run away. Let's just forget this ever happened. Do you order a number 4 you don't have extra large anymore, but or you order a number 4 large with a Coke? Do you cancel the medics because they're 15 minutes away and we don't need them? Do you call for a helicopter and do a landing zone? Oh, by the way, we are 15 minutes away from a trauma center. We triage our patients, or do you pick up the call and do you answer the chief, right? So again, we've already done a kind of a scene assessment. We've already done a little bit of triage. Let's go a little bit more in depth with our triage. So we've got 3 patients that we know that we're working on. We've got 1 that's essentially dead. We've got 2 others that have some semblance of life. So we should be triaging and deciding again, priorities, priorities, priorities. In pretty short order, you have 3 ambulances on scene. Patient 1 is still dead with CPR going on. Massive head wound, gray matter all over the parking lot. Patient number 2, stable vital signs, ANO times 3, but has increasing abdominal pain and his heart rate has gone from low 100s to now 130. Patient number three, bleeding is controlled and is through and through gunshot wound to the hand. There's no neuro or vascular deficits to the hand and possibly fractured. Medics are still about 5 to 7 minutes out as you've done your triage and patients are being loaded. So what are you going to do? What are we doing with patient one, patient two, patient three? Who's going first? Are we going to hang around and wait for medics to show up, right? All right. So you are, like it or not, the incident commander in the scene because the chief isn't there yet. He was calling. You decided not to answer. Smart move, not smart move. I guess you'll find out after the call. But as the incident commander, all right, whether you've declared this as an MCI or not, you are still the person in charge. You are going to have to prioritize the patient. So which one is going to go and what's going to be the hospital destination of choice? By the way, you do have two trauma centers to choose from. We're pretty lucky. We have a trauma center that's 15 minutes away and we have a trauma center that's 20 minutes away, opposite directions of one another. So what do you want to do? Patient number one, gunshot wound to the head. Patient dead. Patient number two, abdominal wound, increasing tachycardia and abdominal pain. Number three, through and through to the hand, maybe a fractured hand, but no neurovascular compromise. All right. Patient number one, would you call him a red or a yellow trauma? If you're going to work him, if you're going to work him, you're going to call him red, right? He's basically about as red as they're going to get. Most of that red is on the ground. There are some of you that may say, hey, look, dead is dead. We're not going to do anything with him. Well, we haven't declared an MCI. Okay. So if that is the case, then we are probably committed to working this individual, maybe until ALS gets there. Okay. Patient number two, red or yellow? Hmm. Hmm. Yeah. Gunshot wound to the belly, possibly tachycardic because of blood loss. We haven't got a blood pressure yet on him, but we can probably assume with him being tachycardic at 130, he's probably losing blood. So he would be a red trauma triage. Patient number three, red or yellow, and where do we go? Does he even need to go to a trauma center? You know? Theoretically, patient number three is a through and through to the hand. He probably does not need to go to a trauma center because trauma triage guidelines will tell you gunshot wounds that are distal to the elbow or the knees don't necessarily need to go to a trauma center. So we have got two trauma centers, one at 15 minutes away, one 20 minutes away, and we've got a local community hospital that's about 4 minutes away. What are we going to be thinking about him? And is he even a red or a yellow trauma at this point in time? So what the EMT on scene did do is patient number one, because it wasn't an MCI and because we're going to work the patient, medics are still 7 minutes out. They went ahead and elected that they would go ahead and work the patient and transfer him to one of the mutual aid units to go to the level one trauma center, which is again 15 minutes away. Patient number two, which is the abdominal pain with the hemodynamic instability, that was also triaged to go to the level one trauma center 15 minutes away. And then patient number three, they triaged that as a yellow trauma. They knew that probably it could go to a non-trauma center, but they also knew that that local hospital probably would pitch a bitch if we pulled in with a gunshot wound to any part of the body. So they went ahead and they triaged that yellow to go to the secondary trauma center, which was 20 minutes away. It is a level two trauma center. So that was the triage rule that they made. And I think they made the right decisions. I mean, you can argue about gunshot wound to the head with gray matter, whether or not that was a survivable injury and whether or not you needed to work them at all. And again, that's a judgment call at the time that you're working that patient. All right, let's go case number three, ejected on the circle. This is the Somerville Circle, the infamous, the notorious Somerville Circle. All right. So we get dispatched to the Somerville Circle, motor vehicle crash, rollover with ejection. En route, we hear from PD on the scene. They tell us and they tell dispatch the crash occurred on the exit ramp of about a 50-mile-an-hour highway, exiting onto the circle. Apparently, the person came off the highway a little too fast, rolled the car multiple times, and was ejected, and looks to be pretty banged up. So, what's running through your head at this point in time? Right? How banged up is he? How far was he ejected? What are we thinking about? How badly injured could he be? Transporting to the hospital, what are we going to do? I mean, do we want to transport him by ground? Do we want to transport him by air? Is he going to a trauma center, right? So what do you think? Somebody who was ejected from a motor vehicle crash, from a car. Yeah. Definitely should go to a trauma center. And the reality is, ejection would be, again, that's a mechanism of injury criteria. So what do we think? Yep. It could be yellow, it could be red. Again, pretty banged up. Let's go with the worst of all evils and say he might be a red trauma. So we're at least working that up at this point in time and thinking, do we want to go by ground? Do we want to go by air? Again, in this particular area, going by air, we don't do very often because, again, we are 15 minutes away from one trauma center, 20 minutes away from another trauma center. And even though aeromedical is not that far away, once we get there, do our initial size up, we can get them loaded and be halfway to the hospital before the helicopter gets dispatched and landed on scene. And then we have to go to a landing zone, which could be another 10 or 15 minutes, delay. So, we're thinking about all. And you, for your particular area of catchment, need to be thinking about these things as you're coming up on scene. All right, we get on scene. We notice it's a single car. Boy, got to work with some of these spelling errors. Single car rollover. One patient's on scene. Witnesses note the patient came off at about what they said about 70 miles an hour with 3 rolls. Victim was ejected on the second roll, and he's 35 feet from the car, lying face down, motionless on your arrival. First thoughts going through your mind is he dead? Right? So we're going to go ahead and we're going to park in a safe distance away. We're going to make sure that if he's laying in the middle of the road, that we've got safety of that scene taken care of, which we do. Police have done a really good job of blocking off egress and ingress into the circle. So, and it's a very busy circle. So we definitely want to keep our wits about ourselves. We want to make sure we got reflective PPE on as we go over and approach the patient. There are no ALS units available. So in the catchment area. So they did go ahead and dispatch medics from a mutual aid medics in. Unfortunately, those mutual aid medics have about a 20-minute ETA. Knowing that, PD asks you if you want to put the bird in the air. Do I want to get that helicopter going? Okay. Again, depending on where you are and what your distance is to a hospital, it may not be a bad idea. State of New Jersey, our fly or drive criteria really looks at about a 30-minute ETA. If it's 30 minutes or longer to a trauma center and you've got a patient who's pretty banged up, then yeah, you might want to get a helicopter involved. If it's less than 30 minutes, which for us, it is, then you may not need a helicopter. It all depends, and it's a judgment call, very much a judgment call. Okay. Again, we've already kind of talked about helicopter would be appropriate for a myriad of different things. You should know your own criteria for calling for aeromedical. Okay. And I hate when they call them the birds. They're not birds, for God's sakes. All right, so what do we know? We know we got a motor vehicle crash with a high-speed mechanism of injury, multiple rolls and ejection. We know the person was found 35 feet from where the vehicle was. So the kinetic energy went on that patient. Pretty decent mechanism of injury, which would lead me to believe that, yeah, he not only needs to go to a trauma center, but, he may be a high-order trauma patient. So we do our primary assessment on him. There's no uncontrolled external bleeding. His airway is intact. His breathing is accelerated and labored. He's breathing about 26 times a minute, but it is bilaterally symmetrical and it is clear bilaterally. Circulation, he's got a heart rate of 122. His skin is cool, pale, and moist. He does not have radial pulses palpated, and he also has a pelvis deformity. What are we thinking here, right? Yeah. Definitely not doing well. Definitely showing some signs of hypovolemic shock. I don't have a blood pressure on him yet, but if he doesn't have a radial pulse, I know his blood pressure is going to be less than 80. And that with a heart rate of greater than 122. If you're not familiar with a shock index, you can watch another video on the Trauma Geek on the shock index. And I would calculate out a shock index to the best I could. If I got a blood pressure, I'd use my systolic blood pressure and I'd take my heart rate and divide it by my systolic blood pressure. And if it's greater than 1, then I have to believe this guy is bleeding until proven otherwise. And even if I don't, based on cool, clammy skin, not having a good radial pulse, and being mildly tachycardic, I'm still hedging the bet that he's got some hypovolemia. And now I think he's got that pelvic deformity. That's never a good thing. Head to toe, multiple contusions to the torso and the extremities. His chest is intact. He's got some pain with palpation along the left side of his chest. He does have decreased breath sounds on the left now. His abdomen is distended and painful, and he's got this pelvis deformity that we've already noted. All right, what's your choice going to be? This one was a bit of a giveaway, wasn't it? And again, whether or not you choose red or yellow, the fact that you choose this and you recognize he needs to go to a trauma center is extremely important. Okay. Again, depending on where you are and where your practice is, taking them to a level one trauma center, a level two trauma center, or if you have level three or four trauma centers, is completely up to you and your protocols. I practice in New Jersey. New Jersey is a small state. We only have level one and level two trauma centers, and about 90% of our level two trauma centers operate at a level one capacity. So it's often a no-brainer, and it's particularly a no-brainer where I am in Somerville because I am literally, again, 15 minutes from a American College of Surgeons level one trauma center, or I should say a state designated level one trauma center, and 20 minutes from a state designated level two trauma center. Both trauma centers are American College of Surgeons level one designated. So it's kind of a no-brainer. For red or yellow, I would certainly classify the guy as a red, a multiple systems injury, high impact mechanism of injury. He's sick and he's gonna need a lot of resources. So boom, he's red right off the bat for me. How am I transporting? Well, you know what? He's going to go by ground. He's going to go by ground because I'm there now with an ambulance. I'm going to be able to get him, flip him, get him into the ambulance, start any treatment I need to do is going to get started en route. ALS, if they're available, they're great to tag on board. But ALS, if they're still, anything more than 1 minute out, then guess what? They're getting left behind in the dust. And we're doing diesel bolus because we do have diesel ambulances and getting him to the closest trauma center, which would be our level one, which is 15 minutes away. All right, next case. We'll call this Burns of Sin. Burns of Sin. We're at the No Tell Motel. Also, used to be on the Somerville Circle. It's not there anymore. There's actually a daycare center there now. How prophetic is that? So it's a No Tell Motel with fire alarm activation. You don't think anything out of it. We get there, we get on scene. As we approach and we get on scene, we are told, we're nearing scene, we are told we have a 26-year-old male who doused himself with lighter fluid and didn't set himself on fire. His girlfriend set him on fire and doused him with lighter fluid after she found him hooking up with her sister at another hotel room in the complex. Not good. You arrive on scene. There's a white male laying on the bed. He's still smoldering with clothes melted to his torso. He's got drug paraphernalia everywhere. The patient is screaming in pain, but tells you he loves his girlfriend despite everything. Mechanism of injury for this guy is we have thermal burns to the face, the anterior chest, and the anterior left arm. He's got a flannel shirt, which is partially melted to his anterior chest. It's red and black flannel, in case you wanted to know. As we pull away the shirt and we can get the shirt away from what we see this kind of a burn. So what do we have here? Some of you may be saying, yeah, it looks like a second-degree burn. We don't call burns first, second, and third degree anymore. We call them superficial burns. We call them partial thickness, partial thickness burns, or deep superficial partial thickness burns, or deep partial thickness burns. Those are old second-degree burns. Or we call them full thickness burns for third-degree burns. So superficial burns for first degree takes the place of first degree. Superficial partial thickness or deep partial thickness is second degree, and then full thickness would be the old third degree. And he's got bubbling, he's got some skin peeling away here. These probably are going to become partially third-degree burns at some point in time. But as we're looking at them now in, the 15 minutes or so since the fire, they're pretty much superficial, partial thickness to deep partial thickness burns. So the old second-degree burns. They are significant. They are also of significance because he's also got them not only to his chest, but an arm as well as his face. So we're worried about, inhalation injury with this guy too. Overall, his mental status is okay. He's ANO times 3. He keeps repeating he wants to see his girlfriend. Primary survey, again, besides the burns, showed that his airway was intact. We did not see any signs of inhalation injury, so he did not have he had no facial hair. His eyebrows were intact. He did not have singed nasal hair. He was not coughing, was not having any problems speaking. There was no swelling in his airway. He was breathing okay at this point in time, a little bit up, but he was pretty agitated. Vital signs there, heart rate of 128, blood pressure of 168 over 98. He's respiring at 24 a minute. He's got a past medical history of substance abuse, anxiety, and depression. All right, so the burns, as previously noted, he's got chest and arm burns that appear to be, again, the superficial and deep partial thickness burns. Again, facial burns appear superficial thickness. We estimate the percentage of body surface area to be, and you don't see it here, but we actually estimated an amount to be about 22% body surface area burn. There were no other signs of trauma on him. And this is where you start using additional triage guidelines, and that's the burn triage guidelines have to come in place here as well. So, what interventions are we going to want to do? First of all, we're thinking in the back of my mind, where are we transporting this guy? So, his mechanism of injury is flame. He has no concomitant trauma other than the burn injury. All right. He has got burns over about 22% of his body, which are superficial partial thickness to deep partial thickness. All right. Um, if we're familiar with our ABA burn center criteria, generally speaking, anyone with a what we used to be a second degree burn, but a partial thickness burn of greater than 20% we need to start fluid resuscitation and we need to get them en route to the hospital. ALS in this particular case is, guess what? Not available. But it's not going to stop us from getting going here, right? So once again, scene time on any trauma patient, all right? If you don't have a scene time benchmark in your agency, you should. Most of them are 10, 15 minutes at the most. Ours is 10 minutes. So 10 minutes off scene. All right, so we do have medics coming, but they're coming from the trauma center in New Brunswick, New Jersey, which is about 15 minutes away. So we're going to probably eventually cross their paths at some point in time, or maybe we're not. We have two other EMTs on scene. They've placed the patient on oxygen. They've covered him in a burn sheet. And based on the information, where are we taking him? All right. So again, his mechanism of injury is strictly a thermal burn. He's got no concomitant traumatic injury except for the burns itself. He's got no imminent problems with airway control. All right. Um, this is a guy who meets burn center criteria. He doesn't have any contraindications to going directly to the burn center, so he should be transferred to the burn center. Now, whether or not we decide to take him by ground or by air, again, that's going to be really based on distance. In this particular case, the burn center is 45 minutes away by ground from where we are. So we elected to call a helicopter and have him transported by helicopter. In burn patients who have concomitant traumatic injury, you are then going to triage them for trauma center routing as opposed to burn center routing, unless you are fortunate enough to have your burn center is also your trauma center. In New Jersey, we have one burn center, excellent burn center at Robert Wood Johnson, St. Barnabas and Robert Wood Johnson facility, but it's 45 minutes away and it's not a trauma center. So if the patient has got traumatic injury, then we are going to go to a trauma center first. Because remember, patients will die from traumatic injuries much more quickly than they will die from their burn injuries. All right, next case study, industrial chaos. Industrial chaos. All right. We get dispatched to the industrial portion of our little town on 4th Street. All we know is it's an industrial accident, not no detail, one injured, unknown extent of injury. Any questions you want to ask before going into service? Yeah, where are we at? Are there chemicals involved? Could this be a hazmat thing? Resources. Do we need some resources? This is an industrial accident. So are we going to need, it's man versus machine possibly? We don't have a lot of details, but let's make some assumptions. So do we want to get some additional resources rolling? And we did. We said, look, you know what? We don't know what's going on. Let's also dispatch out, make sure ALS was dispatched, which they were. Let's also go ahead and dispatch out our technical rescue team, which we have within our organization. So we went ahead and dropped tones for our rescue guys and then went ahead and went in service. We get on scene and you and your EMT partner find a 27-year-old male pinned against a loading dock by a front loader, right? Patient is surrounded by about 8 coworkers, 2 of which are his brothers, all of which are hysterical. Patient is pinned from the waist down. This front loader has pushed him with a pallet of bricks up against the loading dock. So he's really pinned from about the waist down. The loader driver is extremely distraught and he passes out and falls off the loader as you approach the scene. Based on this information, what do you want to do? Was it a good call getting ALS involved? Yeah. Was it a good call getting your technical rescue guys involved? Maybe so. We now have how many patients on scene? We now have our patient who is now compressed, partially compressed. We now have the guy who fell off the loader. All right. Two patients, two EMTs, split, boom, triage. Let's get additional resources for EMS there. All right, so the guy who fell off, he's going to be relatively minor. He vasovagal because he was hyperventilating. Turn our attention to the more serious patient. All right, we end up crush injury, crushed you the pelvis and the lower extremities. Again, this loader has got him pretty well pinned up against the wall. A lot of crushing pressure going on. The loader is stalled and it can't be moved. All right, so you're trying to move it. It will not start. And we don't want to do much else because we don't want to inadvertently hit a knob we don't know about and maybe push the skids further into this guy. Patient's awake and alert. He's in considerable pain. He has got a blood pressure of 102 over 456. He's got a heart rate of 140. His respiratory is 20. He's got no past medical history. We can't really get an appreciation for his injuries. We know his airway is intact. We know his breathing is intact. Circulatory wise, he's got a pretty high heart rate and he's borderline hypotensive. If again, I go back and go to my shock index at this point, 140 divided by 102 is going to give me a shock index of somewhere around probably 1.3. So anything above one or above is considered to be hypovolemic shock until proven otherwise. So he's definitely in the red zone with that. So I got to believe that's going on with him, even though at this point in time, we don't know the full extent of his injuries and God knows what's going to happen when we pull that load off of him. Co-workers are now getting agitated. We're not doing stuff fast enough for this guy. So they are now grabbing the loader and trying to manually push it away, which is now rocking the load and causing increased pain for your patient. What are you going to do? Yeah, hopefully the cops are still on scene. Cops need to get control of the scene and get these people away from that loader. Medics are in town. They're doing a turnaround at the hospital, which is about 4 minutes away at this point in time. Our rescue team is working on removing the stalled loader. Where are we going to take this patient? This is patient number one. We haven't even talked about patient number two yet, right? Oh, wait. Patient number two is an RMA. All right, good. That's good to know. All right, moving on. Where are we taking this guy? We got a community hospital about 4 minutes away. We got the trauma centers. All right. Or we're not really sure. Let's wait and maybe get this load off and, maybe it's nothing wrong with him. Not. All right. The rescue team says it's going to take about 20 minutes to free the patient using airbags. All right. They just cannot get him away. They're just going to have to airbag this thing off of him. It's now 25 minutes since his pinning. The patient remains awake and alert with complaints of lower extremity pain. Given the delay, is there anything else you want to be thinking about? Again, somebody might say we might get a helicopter, up and running. Medics, they're on a turnaround at the hospital. What does that mean? It means they might be out in their chase vehicle and en route to us within the next 30 seconds. It might be they're not free for 15 minutes. So do we call for a helicopter and at least we get the medical staff on a helicopter to be there? Maybe a little bit quicker for us. By the time we call them, they lift up from the helipad, which is about not even a 4 minute flight from us, and land. And then they land in a landing zone, which is going to be away from where we are. And we have to go over and we have to ferry them and shuttle them over. It's a tough thing, but so at this point in time, we did elect to put the helicopter in the air only because we could not get assurances that we'd have medics available. We did know that when we got this thing off of them, which is going to take about another 20 minutes, that he was probably going to need some IVs in him. It probably may start to decompensate. So we wanted to make sure we were okay there. We also knew that having the helicopter there, we would at least have a flight nurse and a flight critical care medic available if all else failed. In this particular case, the patient did have the skid loader. It came down. He did not decompensate. We ended up having The medics arrived about 2 minutes before the helicopter landed. We canceled the helicopter. We got the medics started some IVs in him. They did give him some fluid boluses as they were getting the loader off of him. For whatever reason, it was, one of those good days for this guy. He didn't drop his pressure. He didn't have any reperfusion anomalies like you tend to see with crush injuries. And we were expecting them to happen, but they did not happen. And he ended up being triaged as a red trauma going to the level 1 trauma center. All right. Case study next. Crispy critters, another burn. We are dispatched to an apartment with an oven fire. Upon arrival, we're directed by PD to a 32-year-old male with burns on both of his hands and his chest, 31-year-old female with a burn on her left hand and arm. We have 2 patients. We have 2 EMTs. Do we need to call for additional resources? Absolutely. Are we thinking about where we're transporting him? Well, let's get a little more information. So patient number 1, he was trying to remove a grease fire on a frying pan. The grease splattered on his arms, his legs, and his chest. He's got partial thickness burns, or what we used to call second-degree burns, to both of his hands, his anterior chest, and he's got splattered burns to the arms. Patient number 2 is a female. She grabbed a pan from the male, resulting in superficial and superficial partial thickness burns to her left hand and a splatter burn to her arm. So it looks like pretty low body surface area. All right, treatment priorities. Well, stop the burning process with burns, right? Okay, so we're going to do that. Stop the burning. All right. With this guy, real quickly, we're going to determine body surface area involved. We've already looked at the burns and determined their superficial and superficial partial thickness. We really quickly added up, didn't even use rule of 9s, used rule of palm for this, and we were able to tell he had about a less than 10% body surface area burn on the guy and less than 5% body surface area burn on the lady. No airway involvement, no activity of daily living areas were involved. So no hands, no feet, no perineal areas, no facial injuries. So, yeah, we went ahead and took them to the local hospital. And that was a good call for them because they were relatively minor burns. They were both discharged home. Our last case, jailhouse hanging. We're called to our local jail, which also up until a few years ago was here in town. 19-year-old hanging. On scene, we are taken into a cell block, which is secured by the corrections officers. We find a 19-year-old Hispanic male lying motionless in his cell on the floor. There's a sheet knotted and hanging from the top bunk. Officers witnessed the actual attempt at hanging. Patient sat with the sheet wrapped around his neck, was suspended for about 30 seconds before the officers cut the noose free. So we got a hanging by sheet. There was no drop distance. He was sitting when the sheet was applied. It was a 30-second duration of the noose before he was taken off. Mental status, initially getting in there, he's combative with us. He won't answer our questions. We've got to try to assess him. What can we do? I mean, these are tough ones. If you've ever been in some of these jail cells, the bed squished up against the toilet, squished up against the sink. It's disgusting, right? So first thing is to get him out of that area. So we went ahead and we maintained C-spine immobilization on him. We pulled him out on a bed sheet and we pulled him out into a common area. All right. At this point in time, we have a lot of the other inmates that are screaming at us or throwing stuff. They're not having a good time with us. They don't like seeing us there. They don't like this guy either. So on top of it, they don't want us taking care of him. Vital signs look to be pretty good. Again, he's real combative. He's not answering our questions, but he's also only got a slight bit of redness around his neck. He has a past medical history of being suicidal. He was actually on suicidal watch at the jail until about 2 days ago. He's got a slight redness on the left side of his neck. There's no bruising. There's no pulsatile mass. There's no expanding hematoma. His airway appears intact. He's breathing okay. There were no medics that were dispatched initially. Do you need them? We elected at this point not to need them. They should continue to be uncooperative with the assessment offense. So you've got to do the best you can. It's veterinary medicine at this point. Based on the information we had there, The question became, do we want to take him to the trauma center out of an abundance of precaution? And, he was being uncooperative with us. And, we just couldn't get a really good, assessment on him. So again, we decided to be, again, always be cautious. We elected to go ahead and transport him by ground to the trauma center. Again, he was handcuffed in the back of the rig. He became a little uncooperative. He started screaming and spitting at us. We put a spit hood on him. So clearly, again, he was able to move. We did put a seat collar on him. He ripped the seat collar off once, twice. And then we just decided to leave it off of him. He was moving all of his extremities well. He had definitely torced his neck right and left and up and back multiple times, and he didn't have any paralysis from that. So we went ahead and transported him without the collar, with the spit hood on, handcuffed with two corrections officers to the trauma center out of that abundance of precaution, and made really good friends at the trauma center that night. So that was a good cross section of different patients that we've seen in our little system over a period of time. Any trauma system, or any trauma system, any EMS system will see these types of things. But what I will tell you again, in summary, is regardless of where you are, know your local protocols, know your trauma transfer triage criteria, know your burn center criteria, know what your protocol is for requesting additional resources, know what your protocol is for calling in Aero Medical. All right. Know your trauma triage guidelines for your area. At the bottom of the screen here is the website that you can go to pull down this, as well as a lot of resources on the American College of Surgeons revised 3 years ago trauma triage guidelines, if you're not already using them, and I certainly hope that you are. And I hope you found tonight to be somewhat helpful to you as you kind of put together, red trauma, yellow trauma, and use these new trauma triage criteria for your triage. So, without further ado, I hope you found everything to be very, very helpful. And I'm going to stop sharing my screen here for a minute. And if you are finding the video tonight to be helpful to you, please subscribe to my YouTube video, The Trauma Geek. There's about 30 other videos on here, some hospital-based providers, some for pre-hospital providers. Regardless of where you are in the scheme of things, I think you'll find any of them to be very, very helpful. And again, thanks for joining the Trauma Geek. And if you subscribe, you'll be notified of future videos when they're posted. So be safe out there. Thank you for joining us, and take care.